Hello everyone, welcome back. Today I'll be covering transmetatarsal amputation, a part 1 video. In this video, we start off with an introduction, assessment, treatment, indication for transmetatarsal amputation (TMA), regarding TMA amputation, complication, how to reduce the risk of wound breakdown during transmetatarsal amputation, Equinovarus deformity post-transmetatarsal amputation. I hope it helps. As an introduction, the risk of developing a foot ulceration in diabetic community is around 12 to 25%. Significant contributing factors are presence of neuropathy and peripheral vascular disease. Half of diabetic foot wounds develop an infection. The majority involve soft tissue. Infection and gangrene due to microvascular disease were two major factors that resulted in failure of wound healing, resulting in amputation. Regarding assessment, number 1, the medical assessment and management. A. Stabilization of glycemic control plus or minus insulin sliding scale. B. Stabilization of level of infection via antimicrobial therapy based on clinical presentation and hospital guidelines on diabetic lower limb infection. C. Close monitoring of patient C-reactive protein, full blood count, temperature and blood sugar. Number 2, surgical assessment. A. Determination of extent of infection. B. Assessment of vascular status. C. Assessment of viable soft tissue. Number 3, investigation include glycosylated hemoglobin, C-reactive protein, differential white cell count, the inflammatory markers, culture and sensitivity, Doppler, and X-ray. This X-ray of right foot shows the destruction of the head, neck, and part of the metatarsal bone secondary to osteomyelitic infection. Regarding treatment. Number 1, maintenance of stabilized glycemic control. 2, decompression of infected tissue. A. By incision and drainage where necessary. B. Deep swab with culture and sensitivity and appropriate antibiotic therapy. C. Negative pressure wound therapy. Number 3, monitoring the level of infection and determination of healing potential. 4. Transmetatarsal amputation with adjunctive soft tissue procedure. Number 5. Orthosis rocker bottom shoes with total contact insert. This figure illustrates a different type of rocker whereby the fulcrum location indicated by the vertical red line. The uppermost shows the ankle joint rocker. It inhibits demand for motion at the ankle joint. The below one is a heel rocker, whereby it reduces the ground reactive force to heel. The aim in all cases of diabetic foot infection is to maintain foot function, to preserve structure. Indication for transmetatarsal amputation include wet or dry gangrene involving only the forefoot and/or infection involving the forefoot, osteomyelitis of the metatarsal head and/or proximal phalanx, septic arthritis of the metatarsophalangeal joint (MTPJ), and gross infection of the toe. Regarding transmetatarsal amputation, it involves removal of the forefoot at the level of the metatarsal shaft with the aim of maximizing limb function by maintaining a significant portion of the foot. The primary advantage is the preservation of a viable weight-bearing platform allowing early ambulation, thus enabling the patient to maintain their independence while maintaining a more acceptable appearance as it may disguise with footwear. A partial foot amputation also results in less expenditure of energy during ambulation than more proximal amputation, facilitating mobility and independence. Compared to a more proximal amputation, the procedure proved to be most favorable option with regard to patient satisfaction and function. Regarding complication, Anthony et al. Reported that 82% of patients post-transmetatarsal amputation required further surgery due to post-operative complication. Pollard et al. Conclude the need for more proximal amputation in 32% of cases. Most significant problems with transmetatarsal amputation is difficulty in predicting successful wound healing. So, incision planning is crucial in number 1, providing necessary surgical exposure, and number 2, maximizing the use of viable soft tissue. How to reduce risk of wound breakdown in transmetatarsal amputation. After proper incision planning, a fish mouth incision is made as distally as possible to maintain as much length as possible and ensure an adequate plantar flap can be brought dorsally, providing the soft tissue protection for the metatarsal head. With the metatarsal head exposed, clear visualization of the metatarsal parabola is possible, and this allows for the pattern to be maintained when resecting the distal portions of the metatarsals. As illustrated, we can see with the metatarsal head exposed, clear visualization of the metatarsal parabola is possible, and this allows for the pattern to be maintained when resecting the distal portion of the metatarsal. You can see the metatarsal head is exposed by the arrow, and after that, there's a plantar flap present. Again, to reduce the risk of wound breakdown in transmetatarsal amputation, the aim is to maintain the metatarsal parabola in attempt to prevent peak pressure points on the stump caused by a prominent metatarsal distally, avascular structures such as tendon stump and the metatarsophalangeal joint plantar plates are resected as this can pose as a nidus for infection. This figure shows the lateral view of the foot, where there is an insertion of the plantar plate to the base of proximal phalanx and synovial attachment around the metatarsal neck. Complication of transmetatarsal amputation. Amputation at the level of metatarsal cause muscular imbalance with resultant equinovarus deformity due to unopposed action of gastrocnemius, tibialis anterior and tibialis posterior, with the loss of tensioning of extensor hallucis longus and extensor digitorum longus. This is addressed by performing a gastrocnemius lengthening and a split tibialis anterior tendon transfer STATT STAT. This figure shows a equinus deformity of the right foot. Yay! We have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.